Welcome to Part 1 of the PRA BC Centralized Orientation session on Indigenous Health in BC. This module will provide background information in preparation for our live session. We have set up this online module in order to allow us to focus on discussing practical strategies that pertain to clinical practice during our live session. Please keep in mind that this module is meant to be viewed in combination with a live session. It is well known that there are large health disparities between the Indigenous peoples of Canada and the rest of the population. These disparities have roots in societal inequities both current and past, compounded by systemic racism within our healthcare system. Without understanding these determinants and confronting systemic racism, healthcare providers risk not only missing the opportunities to mitigate these disparities, but also risk contributing to them. We will review the contributors to health disparities affecting the Indigenous peoples of Canada, and most importantly, we will explore what you can do as a clinician to make a positive difference. This presentation was produced on the traditional and unceded territories of the Squamish, Tsleil-Waututh, and Musqueam nations. I do not possess lived experience from an Indigenous perspective as I am an Asian settler, and I don't have any additional conflict of interest to disclose. I would like to sincerely express my respect and thanks to Dr. Terry Aldred for her expertise, input, and review of this presentation. The focus of our orientation will answer the following questions. First, how is the health status of the Indigenous peoples of Canada different from non-Indigenous Canadians? And second, what can healthcare providers do to reduce this gap? In this online module, we will review the demographics and overview, population health status, as well as the determinants of health. In our live session, we will review healthcare disparities affecting Indigenous Canadians, as well as explore strategies on improving healthcare delivery by addressing implicit bias, applying trauma-informed practice, as well as engaging in equity-oriented practice. In examining what leads up to the poor health status and population health disparity, we will start by examining the adverse determinants of health that leads to a clinical presentation. During the clinical encounter, Indigenous patients experience healthcare disparity, which is a difference in the healthcare received compared to non-Indigenous Canadians. These disparities are mediated by clinician implicit bias, the effect of systemic racism, and the impact of trauma. The cumulative effects leads to the disparities in health status that is observed at a population level. To get us started, we will review some background and demographic information. The term Indigenous refers to the descendants of the original inhabitants of North America. This includes First Nations, Inuit, and Métis people. The Métis people refers to a distinct group of Indigenous people whose early ancestors are of mixed heritage. The Inuit refers to a specific population of Indigenous peoples of northern Canada. And the term First Nations refer to Indigenous people who are neither Métis nor Inuit. 59% of Indigenous peoples in Canada identify as First Nations, while 35% identify as Métis, 4% identify as Inuit. Both in Canada and BC, Indigenous peoples represent approximately 4 to 5% of the population. BC has the second largest population of Indigenous peoples in Canada. In BC, about a third of Indigenous peoples live in large population centers, while 1/3 live in rural areas. The remaining third is split between small and medium population centers. About 60% live off reserve, while 40% live on reserve. There are 198 First Nation communities in BC. Approximately 30 First Nation languages of Canada are spoken in BC. BC is the most linguistically diverse province within Canada, and 7 of Canada's 11 unique language families are located exclusively within BC. To learn more about the traditional territories that you live and work on, check out this crowdsourced mapping project. We unfortunately are not able to cover the wealth of Indigenous knowledge and perspectives on health and wellness within this orientation. It is not possible to appropriately summarize this information as it is not homogeneous across the province. For a general introduction, visit the FNHA website. It is also important to recognize the long-standing history of the Indigenous peoples on this land that is now termed Canada and British Columbia. For an overview, visit the FNHA website. Health service coverage comes from a mixture of provincial government, the First Nations Health Authority, and the communities. Medical service coverage is available through MSP. The FNHA offers additional coverage similar to extended health benefits, including medication, dental care, vision care, transportation and medical appointments, medical supplies, and mental health supports. Many communities offer their own set of services such as early childhood development, home health, and traditional healing. The First Nations Health Authority is a non-geographical health authority within BC with a number of programs and services that support Indigenous health throughout the province. We will now examine the population-level health disparity between Indigenous and non-Indigenous Canadians. Health status indicators reflect the overall health of a population of people. When examining common indicators of population health, it is clear that there is a large gap between health status of Indigenous and non-Indigenous Canadians. One of the most common indicators of population health is life expectancy. There is a 9-year difference in life expectancy between First Nations men and non-Indigenous men. This gap is 10 years among First Nation women. This gap is made more obvious when comparing Canada with its peer countries. This chart shows that the overall Canadian life expectancy is 81.7 years. The life expectancy of Indigenous Canadians is 75.7 years, which is comparable with that of Hungary. This is well below the OECD average of 80.5 years. The neonatal death rate among Indigenous Canadians is 40% higher than non-Indigenous Canadians. First Nations adults have over double the risk of avoidable mortality. Despite the fact that cancer incidence is similar between First Nations women and non-Indigenous women, and in fact lower in First Nations men than non-Indigenous men, cancer mortality is higher in First Nations people in 14 out of 15 of the most common cancers. Disparities are also seen across numerous outcome measures of specific conditions. Through examining these indicators, it is apparent that Indigenous Canadians are not deriving equal benefit from the healthcare system that is meant to serve all Canadians. It is important to make the connection that the current standard of care is what produces this set of population health outcome. In order to improve the population health status, changes need to be made both at the clinician level and at the system level to ensure that the health system meets the needs of Indigenous Canadians. As clinicians, looking for ways to improve the health status of Indigenous Canadians is extremely high yield, given the magnitude of disparity. This also means that we need to maintain a higher index of suspicion for each presentation, given what we know about the population-level health status. We will now shift gears and examine the underlying factors that affect health and illness. The disparities that are observed in health outcome at a population level find their roots in the upstream determinants of health. Inequities in these determinants result in a disproportionately high burden of illness and disease in Indigenous Canadians. By now, most clinicians are familiar with the concept of the determinants of health. Roughly half of our health and wellness is determined by factors stemming from how we live. 15% originate from our biological makeup and 10% from our surrounding environment. Only 25% is attributed to health services. The determinants of health can be broken down into 3 categories: proximal, intermediate, and distal. Proximal determinants directly affect health. Intermediate determinants systematically affect the proximal determinants. Distal determinants affect both the proximal and intermediate determinants. We will start by examining the proximal determinants. Health behavior is arguably the most proximal determinant. It is frequently seen by clinicians as the explanation of overall health status. This may be due to the fact that clinicians have the most exposure to considering health behaviors as risk factors in the course of their training and clinical practice. This is often also resulting in frustration, as clinicians may feel that they have limited skills and resources to address the health behaviors despite being trained to consider them. Some people may believe that Indigenous Canadians have significantly higher risk factors when it comes to health behaviors. Some believe that this is a primary driver of the health disparities. Smoking and alcohol use are 2 examples of health behavior indicators. While the rates of smoking is significantly higher among Indigenous Canadians, The rates of alcohol use is similar to non-Indigenous Canadians, if not slightly lower. Rates of recreational substance use and prescription misuse is higher among Indigenous Canadians, although high-quality comparative data has been difficult to find. When it comes to sedentary behavior, the Inuit have higher rates of sedentary behavior, likely due to climate and geography. The rate of sedentary behavior among First Nation and Métis communities are comparable with non-Indigenous Canadians. Studies have also examined the underlying factors that affect health behavior. It turns out that substance use is significantly affected by experiences of trauma. Physical activity and healthy food intake are affected by structural factors such as community food security and the built environment. Put another way, health behavior is the tip of the iceberg that is affected by all other determinants of health. This creates a paradox where society blames health behaviors as the root cause of poor health status, while ignoring the fact that it is impossible to make meaningful gains in health behaviors and overall health status without addressing the remaining determinants. Looking at other proximal determinants of health, we see that housing conditions in First Nations communities are at higher risk of not meeting standards. In First Nations communities, the proportion of people in each income bracket decreases as the income bracket increases, which is quite different compared to the total Canadian population. Similarly, with each increasing education level, there are fewer people in First Nations communities represented. Indigenous Canadians face over 3 times the risk of food insecurity compared to non-Indigenous Canadians. This is linked to poor overall health status and contributes to obesity. Traditional foods confer some protective health benefits. However, climate change disproportionately affects First Nations communities by disrupting access to traditional foods. Overall, it is important to again recognize that the proximal determinants of health are deeply affected by upstream factors such as societal infrastructure and colonialism, which are found in the intermediate and distal determinants of health. Next, we will review some examples of intermediate determinants of health. In-depth review of each intermediate determinant will not be possible within the time that we have. We will therefore focus on community infrastructure and healthcare system as 2 examples. Looking at some examples of intermediate determinants, we can see examples of how underinvestment in infrastructure can affect health. Piped water is more reliable compared to other water sources. However, over 30% of First Nations communities rely on less dependable water sources. 8% lack any type of sanitation systems. Research shows that there is an underrepresentation of media coverage on the issue, and this may be linked to lower public interest and awareness on the issue. While the police is commonly regarded as a source of community safety, the nature of one's interaction with the police can vary depending on race. There is an obvious overrepresentation of Indigenous people affected by street checks, which are police-initiated encounters that are not prompted by reasonable suspicion of criminal activity. In addition, Indigenous peoples are 10 times more likely to be killed by a police officer. Common rhetoric would dictate that one does not need to be afraid of the police if one is not doing anything illegal. However, statistics would indicate that Indigenous peoples are at higher risk of being involved in the police encounter just by going about their daily life. The greater risk of police violence can also deter Indigenous people from seeking help from the police. Across the board, Indigenous peoples face a significantly higher rate of incarceration. In fact, the rate of incarceration is so significant that Indigenous men lose 76 times more years of life to incarceration than to cancer. Not only does this highlight incarceration as a significant determinant of health for Indigenous Canadians, but it also is a marker of concern on the equitable administration of justice. The child welfare system is another aspect of community infrastructure where there are significant disparities. The rate of investigation into child welfare in First Nations children is 4.2 times higher than non-Indigenous children. Indigenous status is significantly associated with subsequent decision to place a child in care. Despite representing only 5% of the youth population, Indigenous people represent 50% of the youth population under government care. Not surprisingly, this further affects the willingness of Indigenous people to interact with authorities and public services. One study shows that when child apprehension is being threatened, Indigenous women would still seek healthcare for their children, but they would be less likely to seek healthcare for themselves. The legacy of oppression through child welfare services is not new. During the 1950s and 60s, there was a sharp rise in the rate of removal of Indigenous children from their families in favor of adoption and foster care placement. Families that were unable to provide what was perceived as a mainstream middle-class upbringing risked losing their children to placement. There are reports that some children removed at a young age were not told of their Indigenous heritage. Collectively, this led to a significant part of a generation that lost culture, family connections, and identity. With the known population-level health disparity, the healthcare system itself is an obvious area to examine for barriers disproportionately affecting Indigenous peoples. No matter how good a healthcare system may otherwise be, barriers to access that affect a specific group of people would conceivably lead to health disparities. One study in Ontario looked at health system use by First Nation people with diabetes. People with diabetes require excellent primary care and would ideally have an 100% attachment rate to family physicians. For non-Indigenous people, the attachment rate comes close at 97.7% compared to 85.3% for First Nations patients. Even for those who have a family physician, continuity of care tends to be lower. The proportion that are under the care of specialists is also lower. There is a twofold higher risk of admission for ambulatory care sensitive conditions and emergency department visits for hypo or hyperglycemia. Overall, this reflects a poorer level of primary care for First Nations patients compared to the general population. The perception of health services amongst the same group of patients is revealing. 18% reported that they have not received needed health care in the past year, while 24% rated their care as being worse than other Canadians. 15% report unfair or inappropriate treatment from a healthcare provider in the past year. This reflects poor therapeutic alliance and a trusting relationship that will be required for high-quality healthcare. Research examining barriers to healthcare access reveal 4 themes. First, trauma stemming from the healthcare system resulting in a reluctance to seek healthcare. Second, stereotype and discrimination experienced during healthcare episodes. Third, poor communication throughout the healthcare encounter. And fourth, lack of sensitivity to context and culture. We'll briefly explore these themes. There are numerous examples where oppression and trauma was actively perpetrated by the healthcare system and healthcare providers. One prominent example are Indian hospitals, which were created to treat specific disease such as tuberculosis and segregated Indigenous patients from other Canadians. There were numerous reports of poor conditions and acts of malpractice, which has resulted in lasting distrust of the medical system. Between the 1940s and 50s, government researchers conducted nutrition deprivation experiments where select nutrients were deliberately withheld from nutrition programs in order to identify the effects of malnutrition on children. These experiments were performed without consent and involved at least 1,300 people. Women in the Saskatoon Health Region began coming forward with reports that brought to question the consent process of tubal ligation surgeries. There were numerous accounts of women being asked for consent for tubal ligation while in labor. There were other accounts where women provided consent to tubal ligation, but later realized that it was a permanent procedure. Qualitative research on patient experience identified a common theme. Stereotype and discrimination are commonly reported as part of the healthcare experience of Indigenous patients. There is a common sentiment of blame towards Indigenous peoples for their health status and the failure among providers in understanding the role of determinants of health. Research on the attitudes of providers also show that negative stereotypes and assumptions are common. There are also examples of overt discriminatory comments and gestures, as noted by trainees such as medical students. One tragic example involves Mr. Brian St. Clair, who was sent to the emergency department by a concerned primary care provider from a clinic. Due to an initial error, a chart was never created for him. While he waited for 34 hours in the waiting room, His presence was repeatedly noted by nurses and security personnel, none of whom took direct action to verify whether he was a patient and why he was not yet seen by a physician, despite the fact that Mr. Sinclair eventually vomited and other patients in the waiting room voiced their concerns for his well-being. He was eventually found dead by another patient in the waiting room after rigor mortis had already set in. He had developed peritonitis from acute cystitis. Racism was cited as a factor in an external review, which found this to be a preventable death. There are also examples of explicit racism by healthcare providers. Michelle Lebrec visited the emergency department for abdominal pain and received what she thought was a genuine prescription that was folded up and given to her. She discovered later that there was a crossed-out beer bottle drawn on the prescription pad that she received. There are also recent reports that physicians and nurses in emergency departments would play a game to try and guess the blood alcohol level of patients appearing to be Indigenous. Joyce Eshkwan was admitted to hospital for abdominal pain. She made a live video of herself documenting her pain. The video captured nurses and other healthcare workers directing insults at her. She died 2 days after being admitted to hospital. These reports of stereotype discrimination and explicit racism within the healthcare system have resulted in care avoidance among Indigenous patients and foster fear in those who do choose to seek care. Even in the absence of explicit racism, patients report poor communication as a hallmark of their care. Many report feeling that they're being given a runaround. There may also be palpable negative sentiments expressed through nonverbal cues. Patients report feeling like they're not believed and that providers are not taking the time to explain the care process. This impairs the ability of patients to form a trusting relationship with a provider and to participate in their care in an informed manner. One participant shared the following in a talking circle. They treated me like crap and I know it was because I was Native. We all know because of the look. There is a look. When you need the medical care, we put up with it. We shouldn't have to. We bleed the same way, we birth the same way, we have no choice. Another participant shared the following. I don't really like coming to the emergency department, but where is a guy supposed to go? And again, is it because I may look like a street person? Maybe it's because I'm Native. I don't know. Even when care is provided with the best of intentions, many structural factors and provider blind spots create a care environment that lacks sensitivity to culture and context. An example is appointment systems that are inflexible that makes it difficult for patients to attend appointments when traveling from rural communities. Extended families can be very important in the healing process for patients in many cultures. However, many hospitals have restrictions on the number of family members who may visit or be involved in a person's care. Lack of female healthcare providers can be a significant barrier for female survivors of sexual trauma who seek care. Many find that there are little avenues to incorporate traditional practices in their care. Due to poor access to community primary care, many Indigenous patients need to seek primary care in the emergency department. However, many find that their presentation is met with scrutiny and may feel accused that they are making unnecessary visits. Indigenous patients are very aware of the number of ways that the health system contributes to the traumatization and oppression of Indigenous patients. This can create a disincentive to seek care even in those who have not personally experienced it. This results in delayed care or even care avoidance. Not surprisingly, research shows that discrimination by healthcare providers is positively associated with unmet health needs. Patients who feel that their health services are not culturally appropriate were found to be more likely to have diabetes. In summary, barriers to healthcare system access translates into tangible adverse health outcomes. Here are some of the articles that were referenced in the above section on the healthcare system. We will now examine some examples of distal determinants of health. Negative sentiments towards Indigenous Canadians are prevalent throughout society. One example is the idea that Indigenous peoples have a sense of entitlement. Another common sentiment is that of blame towards Indigenous peoples for the inequities faced. There are numerous examples where people express these sentiments explicitly through active social exclusion towards Indigenous Canadians. The target of these sentiments also include youth engaged in team sports. Advocacy for equity itself can also serve to attract acts of hate and discrimination. One study shows that Indigenous university students experience 2 to 3 times more racism than do African and Latino Americans in the United States, with 80% reporting experiences of racial discrimination. Closer connection with traditional culture increases the likelihood of experiencing discrimination. Racism has a direct impact on health. Indigenous students who experience racial discrimination have more pronounced wear and tear on the neuroendocrine, cardiovascular, metabolic, and immune system when numerous biochemical or physiological markers are assessed. This stress-induced wear and tear is known as allostatic load. Cultural continuity mitigates the allostatic load caused by discrimination, but it can also increase the risk of attracting more discrimination. Racial discrimination is associated with chronic diseases as well as chronic disease risk factors. Discrimination against Indigenous Canadians started in the early days of Canadian colonialism. One prominent mechanism in laying the groundwork for societal inequity is the Indian Act. Through various iterations of the law, Indigenous peoples suffered limitations of autonomy and disruption of traditional governance structures. The law also prohibited political organization to advocate for Indigenous rights and welfare. Until 1960, First Nations people could not vote in federal election without losing treaty status, which conferred important rights. Indigenous Canadians were prohibited in retaining legal counsel to bring claims against the government or non-Indigenous people. Women could lose treaty status by marrying a non-Indigenous person, while the same does not apply to men, creating gender inequality in legal status. Prohibitions on traditional practices resulted not only in the loss of culture, but was also used as justification for the theft of objects of traditional, spiritual, or artistic significance. The law limited the ability to achieve economic prosperity in order to prevent competition against settlers by limiting the ability to sell farm products. While movement off reserves was not explicitly part of the Indian Act, it has been used to justify a pass system intended to restrict movements off reserves. These are just some of the ways that the Indian Act has laid the groundwork for societal inequity. Despite the majority of the overtly racist elements being repealed in its current iteration, the legacy that the Indian Act leaves in creating inequity continues to have a profound impact. The Indian Act created the reserve system, which set aside Crown land for the exclusive use of an Indian band. This was a mechanism used to allocate land for the use of Indigenous peoples while facilitating appropriation of land for the use of settlers. This also entrenched inequity by preventing land ownership and resulted in loss of access to traditional land. In the 1870s, the Canadian government created the residential school system in an attempt to assimilate Indigenous children into Canadian society. The explicitly stated goal was to, quote, kill the Indian in the child, end quote. There were over 130 residential schools across Canada with over 150,000 attendees. These schools were mandatory until 1948, with threats of imprisonment for parents who refused to send their children. Students lost connection with family as they were forced to be away from home for much of the year. Students were forbidden to practice culture and speak Indigenous languages. There were many documented accounts of forced labor, substandard living conditions, as well as severe physical and sexual abuse. Despite the stated objective being education, much of the teaching staff have no professional training in education. Despite its devastating impact, non-Indigenous Canadians had limited awareness of residential schools until coverage increased recently on the work of the Truth and Reconciliation Commission. In 2008, roughly half of Canadians had heard about residential schools. In 2016, this number only increased to 2/3. Despite the fact that the explicitly stated objective of residential schools was to destroy Indigenous culture and connection to land for the purpose of forced assimilation, a significant portion of Canadians did not believe this to be the case. Residential school attendance has been linked to negative health outcomes. The effect is not only limited to those who have personally attended residential school. Individuals whose mothers have attended residential schools had a moderate increase in allostatic load regardless of whether they were raised by their biological mothers. Looking back at the determinants of health, Indigenous Canadians face significant inequity throughout the proximal, intermediate, and distal determinants. This systematic deprivation of the means to achieve health and well-being has been termed structural violence. Some current work is ongoing in defining determinants of health in ways that are more relevant to Indigenous Canadians. This can be instrumental in moving forward on improving health equity. In closing, Indigenous Canadians face significant barriers across almost all determinants of health compared to non-Indigenous Canadians. These adverse determinants likely contribute to the significant gap in population health status we examined earlier. Viewing this from a clinical lens, the awareness that there are disparities in health status should, at minimum, increase the index of suspicion with each patient encounter, as the prevalence of clinically significant disease and the risk of poor health outcome are higher. An understanding of the adverse determinants should provide a lens into the barriers that patients face along their health journey and counteract the blaming of patients for their health status. On a deeper level, this understanding offers an insight into patients' unmet needs and offers powerful evidence that equitable care is not the same as equal care. In order to work towards health equity and reduce the gap in health status, offering the same care to all patients is not adequate. In our live session, we will explore what clinicians can do to reduce our contribution to healthcare disparity and enhance our ability to help close the gap in population health outcome. So far, we have explored how the downstream poor health status has roots in the adverse determinants of health. In our live session, we will examine how clinicians can avoid disparities in healthcare delivery and alleviate the impact of adverse determinants of health by addressing implicit bias, systemic racism, and the impact of trauma. Thank you for your time and attention. We'll see you at the live session.